Pablo, it's really nice that you accorded us some time that we can interview you for the quality of life. So, yeah, I think just for a start, what I would like to know would be, how did you come in contact with the topic quality of life, and what fascinates you about this topic?
The history started in the middle of the 19th decade. At that time, I was working for a pharmaceutical company, and in addition to having heard about quality of life evaluations to colleagues, etc., in this company there was a clinical trial using a global quality of life instrument for evaluation, the Nottingham Health Profile. I saw the results and I said, my God, this is very interesting. In addition, in 1995, the group of Oxford published the PDQ-39, the first quality of life instrument specific for Parkinson's disease. Immediately, I was in contact with the authors and obtained the permission for make the validation of the instrument in Spanish. This was the starting of the beginning of the history. Really, I was very fascinated by the topic because I was working in clinical assessment of patients. At that time, the only instruments we had were rating scales and questionnaires in order to evaluate symptoms, signs, disability, etc. But quality of life evaluation offered a different type of assessment that we can say was the evaluation of the disease and the consequences of the disease from the perspective of the patients themselves. This is a new way of acquiring information about a disease, and there is it's not maybe not substituted by any other clinical evaluation. So these were the reasons why I was interested in quality of life. It was challenging but very exciting too.
Yeah. And to go back, because we had a discussion yesterday about quality of life. So the definition or the wording quality of life is quite broad. So could you perhaps explain for you what the definition of quality of life is, and then also the difference, because the quality of life, which is used basically in the questionnaire, is health-related quality of life, which is a huge difference. And I would like that you re-explain this to us, because I think it's very important to understand that also for the broader public.
First point about this question is that there is not a universally recognized definition of quality of life. So there are many. There are dozens of definitions of quality of life. Perhaps one of the most popular is one by Kalman and co-workers that said that quality of life is the gap or the difference between hopes and expectations and the real situation. This comparison makes the people put the level in which the quality of life for them is. But this is global quality of life. Global quality of life has a lot of components, and one of them is health-related quality of life. While the sociologists and the politicians and psychologists, etc., may be interested in global quality of life, doctors and health workers are more interested in health-related quality of life, that's to say, in one of the components of the global concept of quality of life. The health-related quality of life is, we can say, is the part of the quality of life which is directly related with the health state, the care, and all aspects related with these situations. And therefore is much more restricted in concept of global quality of life, and it may be defined in some way like my definition in 1998 was that is the perception and evaluation by patients themselves of their consequences of the disease, the impact of the disease and its consequences on their lives, on their lives. So this is the concept I used because I wanted to highlight the perception and self-evaluation in one hand, and on the other hand, the impact of the disease and its consequences, including, for instance, the treatment, the consequences of the treatment too.
Mm-hmm. And what do you think is so challenging in evaluating the quality of life? What is the challenging point about it?
One of the most important aspects in this, for answering this situation, is that quality of life is a subjective and individual concept. Therefore, each person has a concept of quality of life. Therefore, to develop a measure able to evaluate the quality of life in people would be almost impossible. But the strategy is to develop the measure thinking in which kind of population is going to be used. In this, once you have this answer, you can include in the development team people representing the target population. You can extract the most important things for this kind of population. You can also take information from experts in the area. You can review the literature in regard to the topic you are going to work on, etc. And finally, you define a series of domains and items, etc., that may be put together in order to construct one of these instruments. There are also instruments of global evaluation. For instance, how is your health state today? Mm-hmm. Is the only question. And there is a gradation, and the people put the mark, the note, where they perceive the health is. So it's difficult, but finally the application of psychometric theories and other theories about social markers, etc., have been put together in order to produce these kinds of instruments using a specific methodology for the development, and also under the rules of international consensus for that, in such a way that finally we are able to obtain questionnaires which are really scientific measures and are able to produce reliable, valid, and other type of characteristics typical from the scientific measures, like outcomes after their application. Yeah. So the procedure is complex, but after that, the development is possible and they work very well.
So in total, what you say is, to capture quality of life in particular is almost impossible because it's not concentrated on a certain topic, but it was able to capture it in the topic of Parkinson's disease because you said, okay, it's really focused on a certain aspect of the disease of this patient, and therefore you could go into the depth to develop that scale. And I still remember what we talked about yesterday, so I would like you to illustrate again. So when you have patients, how do you develop these questionnaires? Because we talked about it also yesterday. If you see these questions, they are quite negative. They are concentrated basically on the negative aspects of the disease. Mm-hmm. So one, you could say, why is that so? And I would like to know, okay, how basically did you develop them together also with the patients, and how did you filter out the important aspects which are finally evaluated?
First of all, the instrument we usually apply, for instance, in clinical practice and research, are collective, we can say. So they include the aspects that are more relevant for most of the patients with this kind of disease, or the aspect of health which are more relevant for general population. There are also instruments able to offer information about one individual. In these instruments, the individual is able to identify the areas most important for him or her, and after the identification, the people are able to quantify how satisfied are with, or how problematic is this area for them, etc. So we can obtain information about this person, this particular person. But obviously in a clinical trial or an epidemiological study or in clinical practice, we look for the collective information valid for most of patients, we can say. Like the procedure for development of the scales is so complex, and I told you that we expect that we start the development with qualitative studies obtained from the target population. For instance, in medicine, obviously, the target population is always people with a kind of disease or with health problems. Obviously, the questions and the interview and the spontaneous speaking of this person is about the problems they have. And this is perhaps why these instruments always are born with a tendency to the negative aspects of the health, because we are evaluating symptoms, disability, problems with a lot of things, for instance, problems with social relationship, with the family, economical problems derived from the disease, etc. So the focus in disease is difficult to be positive, because the disease bears a negative impact on the persons.
Yeah. Do you think it would be possible to evaluate with a questionnaire something positive, and would it be possible to empower the patients with some of the questions? That means, I give a concrete example, that the questionnaire about quality of life would be possible to ask a patient what he still can do, which is very much individual, I know, but in the same time, when you ask a patient, okay, what can you still do, it empowers the patient, because he gets conscious about the fact which are all the things he can still do, and concentrate also on the positive things, because in the whole relationship you have with the doctor and the disease, you're always talking about, of course, the negative things, because we want to treat them, but we don't give empowerment to the patient in this aspect. So
I think that this kind of focus is out of the consideration when we are speaking about health-related quality of life assessment in medicine.
Yeah.
Because, as I said, we are focusing the interest on patients with problems, and we are interested in knowing the impact of this problem on them, and they are interested in let us know how important are these problems for them. Speaking about Parkinson's disease, for instance, you know, people with Parkinson's disease have motor signs and symptoms, non-motor signs and symptoms, problems with cognition and mood, disability, long collection of non-motor symptoms, and etc. In this situation, it's difficult to to use simultaneously that are evaluating how the disease is affecting the person, to use something for empowering the person to be better. I think that this is another kind of approach to the patient, probably done with different instruments, different practices, but it's not, at least in this area I've been not working never. I've been interested in evaluating the disease and the patient and the disease.
You said yesterday one thing which I like you to repeat another time, because you talked about the questionnaire, and we were challenging you and telling, yeah, it's more the negative part which are brought up. So a patient says, okay, is this going to happen to me if he doesn't have the symptoms yet? Mm-hmm. What would you say is important when the patient is filled out, and what's the positive thing of such a questionnaire? Why is it so important also in clinical practice to applicate a questionnaire about health-related quality of life?
I think that one of the most positive aspects of application of a quality of life instrument to patients is that they are able to report through the questionnaire a variety of problems that usually don't arise in the usual visit to in the hospital or in the health center. If you remember, until 15 or 20 years ago, Parkinson's disease was a purely, we can say, motor disease, motor problem. And the conversation with patients in the office were about the tremor, the ability for walking, etc. This now has moved to a different level, because we are now interested in motor and also in non-motor symptoms, which are very important. Frequently, the non-motor symptoms have more impact on patients than motor symptoms in their quality of life and disability, etc. When the patients see the questionnaire, maybe that says, oh, I don't have several of the problems they say that patients with this kind of disorder manifest. That means that I will have in the future this may be a question. Obviously, if the patient has this doubt, the best he or she can do is to speak with the doctor. The doctor will say probably that the diseases are never the same in different individuals, and they are this kind of questionnaire try to include everything that may be important for most patients, but as I said before, the collective doesn't represent really each individual. And one person may have a problem that other person with the same disease has not, and this may remain so for the rest of the disease. For instance, there are patients with a lot of sleep disorders, whereas there are others that sleep disorders are not so important, like for instance constipation or falls, and it's not frequent that patients have everything that appears in the questionnaire. We had the experience with the non-motor symptoms questionnaire, and there is a Gauss bell in the number of non-motor symptoms that patients can present, and there are patients with 2, 3 non-motor symptoms, and there are patients with 25. So it depends on.
So one of the things you mentioned also yesterday, and that was the point you were pointing out now also about the questionnaire. So in clinical practice and from your experience, when you asked the patients when they filled out the questionnaire, you said they were very grateful to fill out a questionnaire because they could address problems they were normally not using or not referring in a usual clinical setting with the doctor. So what would you recommend to the patients or what would be your recommendations for the patients to use this kind of a questionnaire? What would be the advantage?
I would say that the recommendation would be for the doctors.
Yeah.
The doctors will have to provide the patient with several of these questionnaires in order to ask to them that the day before of the next visit, for instance, they come with the questionnaire completed. This would be very interesting because usually the time we have in the office for evaluation of patients is quite limited, and during this small amount of time it's impossible to ask for each of the aspects that may be causing problems to the patient. However, if the patient comes from home with the questionnaire completed the day before or the day before, we rapidly, at a glance, are able to identify problems, to compare with the problems of the past visit, and immediately we are able to capture if things are going well or not in several of these problems. So I think that they are very useful and are very pragmatic in order to obtain wide information about the disease. Maybe that today there are a collection of different types of questionnaires, but we can use this questionnaire, for instance, for non-motor symptoms, for quality of life, for disability, etc. Well, you can select those that are more relevant for the patient you are going to evaluate and provide this kind of instruments in order that the patient can inform to the doctor about the problems he or she is suffering.
Yeah. So basically the fascinating thing is you can use it for studies and you can compare patients and a certain population within, but on the other hand side you can individualize it down, so you can break it down to the point that you can use basically certain aspects of the questionnaire and you can quantify the problems for the patient, and you can then concentrate in clinical practice on these points and change also the treatment strategy. I would say also it gives the patient the possibility to prepare on a consultation because it makes him reflect on certain aspects of his disease and somehow also get coordinated, because of course when you come into a consultation you want to address everything. But I think if you fill out a questionnaire at the end, it makes you think, okay, which are my main symptoms and which I want to address to the doctor during the limited time of consultation.
For instance, we have the experience with the non-motor symptoms that a proportion of patients, maybe 30–40%, discover through the non-motor symptoms questionnaire that these problems were related with the disease. For instance, I can say urinary problems. Many patients are not able to put together Parkinson's disease, for instance, with urinary problems, because they can think that it's a problem of aging, not the disease. However, through the questionnaire, said, so
there is a connection.
This is important. There are another type of experiences that may be discovered by the patient, and in the next visit can ask to doctor about, doctor, this is really related with the disease. And for many of them are very, it's like a liberation of the doubts and the stress, because they discover that the experiences they have are not very strange, are a part of the disease. For instance, illusions in relation with the treatment. I'm the, the, the patients can live this situation in a very dramatic way. However, when they discover that if they don't speak about this, never with the wife or with the spouse or with the children or with the doctor even. So when they discover that they may be related to the disease and the treatment, I have this problem. Maybe in this case, may be very useful for them.
It helps to address taboo themes too, because some of them are not easily addressed, and the scale gives you the possibility as a platform to talk about it.
We were yesterday spoken about sexual functioning that usually is avoided in the interview with patients. Nobody asks about, and the patients spontaneously probably are not able to raise the questions about. So to have the possibility of expressing the situation through the questionnaire is already very useful for them.
I know we are leaving now a little bit the topic, but I would like to go back to the definition of quality of life, because you said before the difficulty of the definition is because it's very broad, it's very individual, and it's consisting different features. So there are several kind of influences. Can you repeat that again? Because I like the definition you mentioned yesterday so much.
The more than the definition, I'm going to speak about the concept.
Yeah, the concept.
We consider the concept of quality of life, as I said, individual, subjective. Only the person knows how is his or her quality of life. It's multidimensional. So there are several components included in the concept. For global quality of life, for instance, family, social networks, economy, religion and spirituality, environment, freedom, etc. All that are the components of or several of the components of the quality of life concept. In health, despite to be more restricted concept, is also multidimensional. And the basic dimensions we include in the health-related quality of life are in close relationship with the definition of health that the World Health Organization did in 1948, when said health is the well-being in physical, mental, and social aspect, and not the merely absence of disease of infirmity. So physical, mental, and social are the basic components of the concept health-related quality of life. Physical is represented by symptoms and manifestations of the disease. The mental aspect is the functioning in cognitive and emotional aspects. Functional situation is their ability to do things, the daily life, etc. And from the point of view of social, this is usually represented by activities, social activities, and role activities that can be done or not due to the disease. For instance, stigmatization that is produced by several diseases tends to isolate the individual from the others because he is stigmatized. He feels that people perceives he is a patient with one of these problems. So this is more or less the basic components of the concept quality of life. There may be other, for instance, global concept, global judgments about health. My global health is good or is not, maybe also included in the instruments or in the concept.
So you said there are several components. Are they equally important, or would you say, it depends? Each individual has a certain, importance for one of the pillars which are used?
Yeah, this is a good question. Usually, when we evaluate these dimensions, we consider the instruments, consider all of them equal, more or less. And finally, we can obtain a score, even one only score, representing the global health-related quality of life.
So the PDQ was basically, done a long time ago now, you have to say that. So you said in 1995. And knowing now what you all know now and projecting it now also to the future, looking back, would you say you would develop or validate the scale the same or in the same way, or would you do it differently now, looking back into the past? And if not, perhaps, what would you do differently?
Yeah, after the PDQ 39, there were another 7 questionnaires, specific questionnaire for Parkinson's disease. And the most used, in spite of that, was PDQ 39. It's very well validated and translated and cross-culturally adapted to many languages and cultures. There are several problems with the PDQ 39. For instance, this instrument doesn't evaluate fatigue, sleep problems, and sexual dysfunction. And there are also small flaws in several of the dimensions. For instance, social support. It frequently has a big floor effect and is not very responsive to treatments, etc. But in general, it's very useful and very complete instruments for quality of life. So I think that probably no other will be developed in the next years, at least that something new appears in the panorama of the disease. And for the future, I think that this kind of instruments, 15 years ago, I said this kind of instrument will be widely used in medicine. And they are. They are in clinical research mainly, not in clinical practice. This is a gap still to be covered. But they are used now continuously. For instance, a clinical trial is almost impossible to appear now without evaluation of quality of life. And maybe that still more in the future because the agencies like Food and Drug Administration have been aware of the importance of the evaluation of the diseases and the effects of the treatment through the patient. They say now that it's absolutely important to hear the voice of the patient in the development of new treatments. And they have published guides about how to develop and how to interpret the outcomes obtained with quality of life instruments. So I think that the future for this kind of evaluation is will be very active.
Yeah. So you think, would there be an aspect which you think is not covered? You said you think it's quite well covered, but there are certain aspects of the non-motor symptoms which are still missing because, of course, at this time when the scale was developed, probably the people weren't aware of the problem of sleep and so forth. But looking into the future, do you think there are certain aspects popping up which will be important to add into such a scale?
Yeah, but the problem is that one of the principles in the elaboration or development of a new instrument, a rating scale or questionnaire, etc., is limitation of the questions.
Yeah.
PDQ 39 has 39 questions, so it's not very recommendable to have questionnaire with 60 or 80 questions. There are questionnaires, for instance, quality of life with even I can say
100,
120 questions. But this is not useful for clinical practice, and even for clinical research may be difficult to apply. So I think that maybe that new approaches to the disease, discover new areas, or like you say, there are several non-motor symptoms that are not considered in the questionnaire, but consider that these questionnaires are not assessing symptoms, are assessing impact of the disease, which is different. In this impact of the disease are included even the symptoms that don't appear in a clear way inside the questionnaire. Imagine this global evaluation I told you before. How is your health today? In this question, you are asking for everything that may be affecting your health or your perception of health.
That's not
maybe
possible.
One symptom or 45. They are included in the same question.
Makes sense. And I think to close the questions for you, I would pose you one last question. That would be, what is your personal definition of quality of life? Because you said before it's very subjective. So what is your personal definition of quality of life for you?
As I told you, my definition of health-related quality of life, because we usually speak about quality of life when really in medicine we are speaking about health-related quality of life.
But if you go broader, it's really quality of life. It's not health-related.
For global quality of life.
What would be your definition for your quality, or your personal definition, if someone asks you what is quality of life for you? And we are not going into the topic of health-related. What would that be? What would your answer be?
I didn't try to make a definition of global quality of life, never. But considering the most popular and some explanations about what is quality of life, for instance, one of them said it's a series of philosophical considerations that about the well-being and satisfaction with things in life that are important for the individual. That's a good definition. Maybe that if I think about this definition 5 more minutes, I say no, but it's quite ambiguous because it doesn't consider, I don't know. I think that having not a universal definition is very difficult to say something coherent now spontaneously. Really, I don't know. I would have to think in depth about this in order to produce a definition.